Hello, everyone. Welcome back to class. Hope you are doing well. Just to let you know, I have been receiving your week 3 homework assignments, and I am getting ready to start reviewing those now. So it's been a pretty busy week, probably been a busy week for you also. But so far, the ones I've seen are looking really good. Hopefully, the assignment is or has been valuable for you in helping you to think about how to search through the research literature and to find articles and to do so in a way that doesn't overwhelm you, because sometimes it can be really overwhelming if there's way too many citations generated with a particular search. And I know I've had conversations with some of you online, and if you've got questions, please reach out to me. Ultimately, you want to get those numbers down low and make your use of time effective. Now, let's assume that you've found articles and it's time to critically evaluate them. So, are the articles that you're finding going to be beneficial for you, not only for your assignment in this class and throughout your research curriculum here at Fox, but are the articles that you find going to have a positive impact on the work that you do as a PA? So, how do we go about this process? And what I'm going to present in this screencast is or are some different ways that you can, different tools you can utilize to help you look at the quality or the strength of an article. Now, put a little asterisk there because this is an initial conversation for us. We're going to be looking at different study designs throughout the term to hopefully help you think about the articles that you're finding. Long story short, I think it ultimately comes down to you understanding what or who your patient population is, and can you find research that helps to answer your question. So what do I mean by that? Well, as I mentioned before, there are different quote unquote checklists or different strategies to critique articles, and we're going to look at those. Is there a standard approach? I'm not sure that I'm familiar with one. And I'm going to introduce something that is new to me, something that your prior instructor of this course would utilize, but it's quite similar to other strategies that I'm familiar with. I think a good starting point always is your PICO. So there's kind of a big picture thing here. We're talking about critiquing the research literature. A good starting point is, what is your PICO? Because you can have potentially great research that you find that's well conducted, but if it doesn't fit your patient population, that's no good, right? So you want to match good quality research, if it's available, to the patient population of interest that you're looking at. So for example, what do I mean by that? Well, what if your PICO is a population of 65-year-old females with osteoporosis? So 65-year-olds or older with osteoporosis. And you're curious about whether or not weight-bearing exercise would be beneficial for these, let's call them sedentary individuals. Let's say that this population is not exercising. And you want to know if weight-bearing exercise would be better than no intervention for changing bone mineral density. So that's your PICO. And you go about doing a literature search like you did last week. And the first study that you find looks like it's covering weight-bearing exercise, no intervention in females that are not exercising. They're looking at the outcome of changes in bone mineral density, but the key feature is these are inactive 20-something females with no history of female athlete triads. So the physiologic status is associated with that. Not really a similar group. It's very possible that there could be some positive changes in the bone mineral density of those 20-something females who are starting a weight-bearing exercise program, but are they similar physiologically to your 65-plus-year-old females? So hopefully you get what I'm kind of illustrating here, in that the weight-bearing exercise could be beneficial. It possibly could be beneficial, but that particular study is not a good one. So that's kind of critiquing at the level of your PICO. And of course, as one's medical provider, you also need to be aware of other things that could potentially help bone mineral density in the population. Could there be beneficial medications? Could nutritional status need to be looked at? Could there be other things that may also be impairing their bone mineral density? So there's a lot as a provider that you would be kind of thinking about and considering. Now, it doesn't mean that that weight-bearing exercise study in the younger females is bad. It could be a very well done, by the book research study, but it might not be good as a study to apply as a therapeutic tool for your population. And I just noticed that I left a key word there near the end of the title. As I said before, the weight-bearing exercise study in the younger females doesn't mean it's bad. It just might not apply as a therapeutic type of study for your population. There may not be a good carryover, or there may be poor generalizability to all females. So again, you ultimately need to draw conclusions based upon current research that you can find to inform patient care. Now, exercise is generally a low-risk example. American College of Lifestyle Medicine, a lot of other groups within the AMA, within other professional healthcare bodies, know the value, the American College of Sports Medicine, know the value of exercise. It's generally low risk. So if you were to prescribe exercise, weight-bearing exercise to your 65-plus-year-old patient population, if they have good balance, that might be a safe thing for them to do. If you refer them to physical therapy, et cetera, to develop a program, that could be good. But where things get more interesting, or where you really have to, I think, be very precise with your critiquing of an article, gets into things that could potentially cause harm, or that could financially not benefit a patient. And that's not the right way of saying that. It could cost the patient money and not yield any benefit. So, for example, if there was a new medication and you wanted to know if that new medication was better than current medications for helping maintain bone mineral density, you would want to make sure that there was efficacy in it. You would not want that person to utilize a drug that maybe wasn't superior and or maybe increase the risk of something else like stroke. Or you wouldn't want to recommend that the individual utilize a supplement that had limited efficacy to it or known efficacy, because it could be something that be financially burdensome to certain individuals. You can imagine some of your population, 65 and older, financially, that could be very costly for them with limited resources. So again, thinking about your PICO, I think is a great starting point, and making sure as you review that article, can you kind of check off, okay, it looks like they addressed the patient population of interest. It addressed the intervention I'm interested in looking at. It addressed that potential comparison. It addressed the outcomes of interest. And did it maybe do it for an appropriate amount of time? I'm going to highlight this article, and this is going to be part of your discussion for this week. As a physical therapist, I can treat patients, or I have treated patients with primary adhesive capsulitis. And through my career, I have treated patients differently based upon early in my career, there was a strategy that we used, and then later in my career, there's a different strategy. I'd like to know what the best way is to provide conservative care for this population. As a therapist, we want to be able to increase range of motion, and then as that range of motion improves, help that individual develop strength again, and do so while minimizing pain as much as possible. Other treatments that a physician might do include medications. I'm talking about like the orthopedist, maybe even manipulation under anesthesia, although that is much rarer to my knowledge at this time. So as a PT, I'd like to know what the best treatment approach is so that I can confidently tell the patient, yes, what we're doing is going to be helpful for you. And I'd also like to be confident that I could talk to a referral source like you and say, working with these patients, here are the expected outcomes with the treatments that we do. That way, you have an appreciation for the potential value of patients coming to physical therapy with this diagnosis. So the PICO is really, really important along those lines. Now, I think it's also important for us to think about the study's validity and to think about that in terms of internal and external validity. So, what is internal validity? That's the degree of confidence that the causal relationship being tested is trustworthy and not influenced by other factors. And we'll look at some examples here in a bit. External validity is the extent to which results from a study can be applied or generalized to other situations, groups, or events. So the validity is influenced by a study's experimental design. And so I think that's important as we look at papers, as you're now going to be moving forward with finding articles related to your study topic of interest. How good are those articles at answering your question? So again, internal validity relates to how well a study is conducted. External validity, how applicable the findings are in the real world. Now, external validity, if you remember back to the weight-bearing exercise example in 20-something-year-old females. Now, the results of this study would not be generalizable to the older adult population. Hence, there could be external threats to validity in that context. Because you could make that argument. The age range is different. Physiologically, there's different things going on. It's very possible, since those women in the 20-something population did not ever have any history of female athlete triad, that those individuals are not comparable. Again, though, it doesn't mean that the study is a bad study. It just doesn't have that external validity to what you're interested in. So keep looking. For example, if you wanted to know about weight-bearing exercise, there's a couple right here. Keep searching the literature. You will find things, most likely. Or if you don't, maybe a study needs to be done. Now let's talk about internal validity threats. Randomized controlled trials, as you've probably talked about in your studies, are what we all want to see, but sometimes those aren't conducted. Sometimes researchers start with something that kind of potentially shows a plausibility, or they are limited in access to things because of resources. So there's other models that can be used, but that potentially creates internal validity threats. So for example, with a quasi-experimental study, there can be a lack of similarity between comparison and intervention groups due to differences in characteristics. Now, let's look kind of at the scoring side of things. How do we critique, or what kind of checklist stuff can we do? First off, this has been an article that has been included in prior courses, and this article is linked in Canvas. So if you aren't confident in your ability to read scholarly articles and want to kind of have a nice overview of things, this article I would recommend for you to read. It's been something that's been assigned before in the past. So review if needed. If you feel confident in your ability to review things, go ahead and skip over this one. So let's look now at some different ways, some different systematic ways that we can potentially critique the literature. First up here is something that has been utilized in your course before, or I should say with prior cohorts that have done this course before. This is linked in Canvas, and it is an online version of an article published in Family Practice Management in 2004. And Dr. Flattery here has proposed the PP icons approach in order to help you appreciate if something is a top piece of research versus something that maybe you could ignore. And so what are the PP icons? Well, it looks like your PICO, right? Your problem and patient population all kind of tie into the same thing. And you can read the article, but basically you've got your PICO right here. And then something that the author talks about, I might disagree a little bit. What I should say is I agree, but not completely. He talks about a paper should have 400 subjects in it, if I remember reading that correctly, that a paper should have a very large number of subjects. And while it's true a large number of subjects in a study is helpful, what a study should maybe have is a report of an a priori sample size estimation. So doing some sort of a statistical calculation to determine the number of subjects that would need to be included in that study in order to show statistical significance if there is the potential for statistical significance. So I have seen award-winning papers with 200 subjects, with 100 subjects. There are probably high-quality studies that have used 50 or 75 patients. It all gets into, again, the type of study that you're doing. Or I should say maybe the type of therapeutic intervention that you're looking at. And then the last one there, the S, is the statistics. the doctor presents some different statistics. These at this time aren't, there's some of the evidence-based practice statistics. I don't know if you've looked at those in your prior year here in the program. From what I'm seeing in this course, this is not something that we're necessarily worried about at this time. So feel free to read through them, review through them there. They may have some value for you, they may not. I'm not talking about it because it may not be something that's necessary for everybody's work with this particular project. That's the PP icons. And the only thing I worry about with this here, and again, the Pico looks just like, your Pico. So you could compare that real quick. Like, don't think, okay, it's got to have 400 subjects for it to be a good study. The Center for Evidence-Based Medicine has a worksheet or worksheets you can use. So critical appraisal is the evaluation of clinical research papers. And does the study address a clearly focused question? Did the study use valid methods to address this question? Are the valid results of this study important? And are these valid, important results applicable to your patient or your population? If the answer to any of these questions is no, then they're recommending save yourself the trouble and don't read through the article. So you're kind of getting an idea, maybe looking at the abstract, maybe reading the introduction and the methods section. And if it doesn't seem like from there that it's going to be what you're looking for, then move on. There is a link to this web page. And what's valuable about it, as you scroll down, there are critical appraisal worksheets. And we'll look at some of these throughout the term. I'm not going to go into depth in any of them this week, but if we clicked on randomized controlled trials, it takes us to something like this. And this is kind of a checklist, so there's much more to it. So you could go and take a look at it right now if you wanted to. Just pause me. And you can slide down it. And again, there's that Pico stuff. And then they give things like, was the assignment of patients randomized, et cetera, et cetera. So there's several things that start to allow you to critique it and think about the study. Here's one that is used in physical therapy, and I don't know if it's used in medicine at all, but it is a checklist like you see there, and it also gives a score. So it scores a paper on a 0 to an 11 score, and the higher the score, the stronger or the higher quality the study is considered. So I just share this with you here because as you look at it, it doesn't say anything specific necessarily to physical therapy. So you could plug and chug any intervention in and appreciate how good that study does on this Pedro scale. So there were a few different things there. We had the one by the physician looking at the Pico, the PP icons. We had the Center for Evidence-Based Medicine looking at critical appraisal tools and coming up with different checklists or kind of sheets to go through things. And we'll explore those more later in those appropriate sections. Those are available for you to check out. There's the Pedro. The Pedro is linked. If you're curious about going to the Pedro website, you can check that out. Ultimately, there is a hierarchy of evidence. But I think an important thing to always keep in the back of your mind is, yes, there's a hierarchy of evidence, but there isn't necessarily quote unquote bad research. There is an understanding on how well that research can potentially influence patient care. So I've written some case reports. Case reports are down here at the bottom. Usually they're considered level 5. If you were a physical therapist and you were reading my case reports, you could use those to inform practice, but that doesn't mean it's necessarily the best way to do practice. But there is value to case reports and case series in medicine. For example, I teach a class in epidemiology for a PhD program at a different university. One of the first papers that reported a unique disease that was later known as HIV, and then, of course, how it progresses in people to AIDS. The first paper that was published was a case series. So it was back in 1980, 1981, New England Journal of Medicine. And case series and case reports are ways that we can communicate findings to others through a peer-reviewed process. So I'm trying to get across that there isn't bad research. We just have to understand its value in either promoting the need to do other research, okay, or its ability to answer clinical questions that could potentially impact patient care. At the top of the pyramid here, systematic reviews. Systematic reviews typically are of randomized controlled trials. So this is linked, and this is an illustration of the different levels of evidence, whether you're looking at diagnosis, prognosis, therapy, harm, or screening, and the types of studies that would be found or would be then qualifying as level 1, level 2, level 3, level 4, level 5. Now, why is it important to kind of think about this for the purposes of critiquing an article? So, for your assignments in this class, it doesn't look like historically this has been required or a part of things. So, for this particular class, whether or not you make note of levels of evidence in your write-up is up to you. Understanding the levels of evidence, this hierarchy here, helps you understand the strength of that study design at answering an important patient-based problem. And it can get you thinking about what are the limitations of the studies that you find. So some of you have some very unique questions. They may not have a lot of randomized controlled trials out there. And so what kind of study designs can you find that can show some plausibility? And then based upon that, what else would you want to know, or what types of studies would you want to see that would increase your confidence that the intervention that you're interested in is superior to what is the standard of care? Knowing the levels of evidence also allows you to quickly screen a paper. So, for example, there are some physical therapy journals, and this was something from one of my publications. Level of evidence 3B was tacked onto it. So that gives you an idea like, oh, okay, that's where that fits. And then finally, if you plan to publish your paper after graduation, and I know that has been something that people have considered in the past, you may be asked to include levels of evidence in your paper. For example, Sports Health, which is a orthopedic surgeon-based journal, kind of a clinical journal, with also collaborations from the American Physical Therapy Association and the National Athletic Trainers Association. They published one of my papers, and study design was required within these tables of the articles that we looked at. And so we had to report the study design and the level of evidence. Now, ultimately, it all boils down to your critical thinking skills. So, for example, lung cancer and smoking. Obviously, we can't do a randomized controlled trial to observe the harm. Why can't we do that? Because we want to do no harm. And it may take a long time. How many people would we have to have start a smoking habit? And how long would we have to observe those individuals in order for an appropriate number of lung cancer cases to occur? What if everybody was Keith Richards? It would take us billions of dollars and thousands of people to continue to monitor that population. It's just not doable. So, what's going to be the best study? A case control study. We'll talk about that in the epidemiologic lecture. Case control studies are lower on the hierarchy, but they would be appropriate in this case. However, if you're looking at a new drug, drug A, and heart function, a randomized control trial with an appropriate patient population observed for a meaningful period of time is warranted. We wouldn't want to do it. We wouldn't want to use the drug if all we had were trials on mice. We might not want to use the drug if we only observe people for a very short period of time. We may want to wait longer to see if there's any increased risks. I'm drawing a blank. I think it was a Vioxx. I think Vioxx was the one, or maybe it was Celebrex. I'm drawing a blank since I'm not a medical person, obviously. It's not my realm to be able to prescribe anything. But in the early 2000s, one of those two drugs, and I'm thinking it was, hold on, I'm going to pause the recording and look it up. It was Vioxx. Yep, it was Vioxx. So sometimes there are drugs that, in this case, beneficial as a anti-inflammatory because it caused less GI disturbance. However, it led to increased risk of stroke. And I think it was a drug that I worked with patients after total knee replacement that would utilize it, if I remember correctly, going back to the early 2000s. Anyways, sometimes, again, my whole point was you might want to make sure that, yes, was that drug utilized for a meaningful period of time. What about the gray areas, though? And this gets into what our kind of homework or our discussion topic is for this week. So this paper by Dirks et al., Gentle Thawing of the Frozen Shoulder, a prospective study of supervised neglect versus intensive physical therapy in 77 patients with frozen shoulder syndrome, followed up for 2 years. Do you recall adhesive capsulitis? So primary adhesive capsulitis, also known as frozen shoulder, is this condition where there is progressive loss of range of motion, there's a thickening or a fibrosis that occurs of the joint capsule, and it's associated with pain. It is called, or is idiopathic at this time. Maybe, what's the known cause? Well, could there be an endocrine disorder component to it? Maybe 2 to 5% of the population experiences it, the general population, but upwards of 30% of the population who have diabetes experiences it. So, and there's been some good case control studies that show an increased risk in individuals with diabetes. So this can happen. It can come on at any time, doesn't have to have trauma associated with it, and it can be very disabling. And there's various stages to it. So it is this musculoskeletal condition, and it seems like it would be perfect for physical therapy. There's loss of range of motion, there's pain, we got to get that range of motion back. Ultimately, we got to build up strength. Well, what this study is looking at is what is the best approach? Is the best approach to look at an intensive physical therapy program, or is it better to just kind of take it easy. And not take it easy like nothing, but you'll see from the article what the physician's recommendations are. So here's your assignment for this discussion topic. Read the article. It's about 4 pages long. And you don't have to think, oh, this is a physical therapy article. No, this is a therapeutic article. There isn't a lot in there on physical therapy. You don't have to know anything about us as physical therapists. It's a treatment article for patients that if you go into orthopedics, you might potentially work with. Review the discussion topic questions that I propose, and then post and respond to peers. And I'll be checking in and making comments too. And don't feel like you have to say, yes, physical therapy is the way to go, et cetera, because I'm a physical therapist. Talk about what you think based upon this article. What are the strengths? What are the weaknesses? And I might agree with you one way or the other. So I think this article will create some interesting discussion because, again, the whole context is, can we look at something? Can it potentially answer a question? In this case, what's the best approach for treating an individual with frozen shoulder? And does that help us with patients in the long run? All right, that's everything